and it was brought me to UK. I did my master's in health management. Whilst working, to make it simple, there are four models of healthcare in general. There are four models of healthcare delivery. The first one probably is called the Beveridge model, which is developed by William Beveridge or Sir William Beveridge in 1948. The hospitals are not managed by the government. So this is the kind of model which is you can have a single insurer model, which is what France and Korea do. So there's only one single insurers through which they're supported, the citizens supported. But in other countries like Germany, Czech, and Czechoslovakia and other places, there are multiple insurers. So the government controls the pricing, and much like the Beveridge model, to mainstream. Complementary therapy has had its own tested history in the UK. It wasn't very well accepted when it started off, but it has become pretty mainstream these days. Definitions. What do you mean by complementary therapy? So complementary therapy could be like homeopathy, Ayurvedic medicines, you have yoga, you have herbal medicines, all that kind of category. And it has become, accepted. Prince Charles was a big advocate of, complementary medicine, and that's sort of, he lent his voice to that, and it has now become mainstay. In addition to that, in terms of some core aspects of, work, especially therapies, anything like what we call as there's music therapy, there is.
Good afternoon, Bala. Welcome to my channel, Digital Wellness. It's really a great pleasure talking to you today.
Good evening to you, Sujata. I'm really looking forward to having this conversation with you.
I saw your interesting profile. You grew up at Chennai, India, and for more than 2 decades now, been at United Kingdom and associated with the healthcare in the United Kingdoms. Can you share your journey, Bala?
Yeah, my first foray into healthcare management came with a personal experience, having grown up in Ooty. My dad was in the defense and was used to the military hospitals. And then when I came down to Chennai to do my graduation, attended an exhibition at the Government General Hospital in Chennai. And it was quite shocking to see how the common citizen was getting healthcare facilities in India. And I made it a point to provide some contribution to our healthcare system from that point of view. My journey brought me to UK. I did my master's in health management. Whilst working in the various aspects of healthcare, I realized how complex healthcare management and healthcare delivery is all about. And the first port of call for me was to get to know what was the government's initiative, society's view on healthcare and health management that they needed to offer for their own citizens. And it enabled me to visualize that and also experience that benefit of a centralized healthcare system that's offered in the UK. Over the years, I managed to specialize in multiple disciplines in healthcare just to get a rounded approach to health management. So I've done quite a lot of work in primary care, which is, I'll come to that, what that actually means. The health is segmented into multiple components within UK. So I've done in primary care, in secondary care, in tertiary care, in community and mental health. And in all aspects of those, in terms of clinical research, in terms of data management, in terms of operational management, and developing innovation and delivery of care within the community.
UK follows the NHS system.
Yeah.
How is that different from the other health systems? I know you've had exposure to the system here in India, but how different is it or comparative is it to the other health systems across the world, Bala?
So to make it simple, there are four models of healthcare in general. There are four models of healthcare delivery. The first one probably is called the Beveridge model, which is developed by William Beveridge or Sir William Beveridge in 1948, which is looking at centralized delivery of care through government. So the government acts as the sole single payer and eliminating competition and it is funded by taxes, and there's no out-of-pocket patient costs, so you don't have to pay at the point of care. And that's kind of the things that the UK follows, where the taxpayers are the citizens receive the care at the point of delivery. And I think the biggest criticism of that model is that, without any restriction, free access could mean overutilization of the system, and also that over a period of time, the cost of care and the cost of taxations could rise. But then it's how the system then has checks and balances. Countries like UK, Spain, New Zealand, Hong Kong, Cuba, all sort of follow that kind of a model, along with the Veterans Association in the US. They follow the same kind of model. The other model is called the Bismarck model, which was sort of coined by the 19th century Otto von Bismarck, which is more decentralized healthcare, where the employees and employers are responsible for the health and the well-being of the person through private insurance. So they set up a health insurance or private insurance plan and they cover, but care itself is provided by private hospitals. The hospitals are not managed by the government. So this is a kind of model which is you can have a single insurer model, which is what France and Korea do. So there's only one single insurer through which they're supported, the citizens supported. But in other countries like Germany, Czech, and Czechoslovakia and other places, there are multiple insurers. So the government controls the pricing, and much like the beverage model, but its service is provided through the private organizations. And then you have this kind of hybrid model, which is called the national insurance model, which is a hybrid of both beverage and the Bismarck model, wherein there's the government acts as a single payer for medical procedures. However, it is all delivered by the private care. So it is a kind of a insurance-led payment, which is the government collects the insurance. So countries like Canada, Taiwan, South Korea tend to use that, and Medicare in US tends to follow that kind of a model. Then you have the fourth model, which is the out-of-pocket model, where the systems are not very well developed, and the government hasn't got the resources to support centralized system. So they tend to have a hybrid of patients paying at the point of care. So this is where this is kind of happens in India, China, and Africa and South America, where there is a parity. If you can afford to pay for your care, you can go to the private healthcare, and pay at the point of care. Whereas there's also they also tend to follow a national health service systems where it is government-led, centralized, and decentralized through regional states or regional government bodies, which then take ownership of that care. But it is very much a mixed economy. That's what happens with the fourth model. The UK per se is made up of 4 nations, as you probably know. It's got England, it's got Scotland, it's got Wales, and Northern Ireland. So the England model is slightly different in the sense the changes are devolved governments. The other 3 are devolved governments, and so we tend to have a kind of an approach to healthcare here, which is more in terms of quasi-market in England. So there is a competition-led driven thing. So we have a purchaser provider kind of thing, or people buy the services. There's a group or body which buys services on behalf of the citizens from the government organizations, and although the funds go from the government to the buyers, and then the buyers then sort of pay back to the providers of care. And then they also have they tend to use private care providers if there is a capacity issue. So there is an agreement that we can use private healthcare, and the government will buy the care on behalf of the population. And from the social care, which is another aspect of healthcare, which is where people are not really patients but they're citizens, are needing support, and that is means tested, which means it's related to the amount of income you earn. So the support you get from the government is related to the amount of money you have earned over your career, or you're still earning as part of your employment. And also there is a prescription charge. So in general, prescriptions used to be free, but then they mandated a prescription charge, so that 90% of prescriptions are exempt from payment, but there's a small 10% is what the population pays for that. In terms of Scotland, there is no quasi-health market. It is completely centralized. The government manages it. There is no there's free social care over the age of 65. There's no means tested in that aspect, and the prescriptions are free. And the same thing is correct for Wales as well. There's no quasi market, and then the prescriptions are free, and social care is very much like what Scotland's have. So the same. So apart from England, all the other three tend to have free prescriptions. No means tested for social care, and they tend to have no quasi market, which is the kind of a competition-led driven things. But all four of them have some element of performance targets that they are measured against in terms of delivery.
Right. So, you also have this concept of trust in the UK, right? There are.
Yes.
How is it? What is the difference between the trusts and the hospitals?
Okay. I touched upon the introduction to say I have experience working primary, secondary, tertiary, community and mental health. So the health market is sort of segmented into multiple blocks. The primary care is led by GP practices or independent physicians. So they are what used to be called family doctors. So in an area, in a location, a GP will have, the citizens will have to register with a particular physician or particular doctor, who then tends to become the family doctor. So every member of the family will be seen by that GP. And a GP practice, tentatively, a single-handed GP practice will have anything between 3,000 patients, 3,000 to 4,000 patients. And then GPs can come together as a group and they form a group practice, and that can have anything between 10 to 12, 14,000 patient population. The idea is that they are the single point of contact for the citizens, and if they feel that the citizen is unwell and citizen needs further care, that the primary care services cannot provide support for them, then they will refer them to the secondary care hospitals, which is basically an acute hospital. So it's a district general hospital is what we call as a secondary hospital. And the secondary hospitals characteristics are they cover all specialities. It's a multi-speciality model, and they will also have an accident emergency unit, so patients can present themselves directly to them. And then you have the tertiary model, which is what we call specialized hospitals. So they are very single specialty hospitals largely, and in some cases they'll be combined, especially in pediatrics. But largely they are single specialty hospitals like cardiology hospitals or cancer hospitals. So they only see that specialty of patients, so that group of patients who come with that kind of condition. And then you have the community, which is care is provided at the community level. So the patients don't have to go to the hospitals. They can be seen in the hospital, discharged, but they'll then be, the follow-up care will be provided within the community. So it'll be community physicians and community nursing staff who will look after them for that care. And then you have the other group, which is mental health. So they are a very select group. So they operate in all across all models in terms of primary, secondary, and tertiary centers, but they're also a separate entity. So they may be specific things. When the government formed this kind of a transformation took place in the NHS, they wanted the NHS organizations to have its own little bit of freedom to make decisions. So the NHS, as we say, is a loose amalgamation of multiple hospitals. It's not a one single big entity. It's a loose amalgamation. They come together. It's centrally managed, but each of the organizations are independent. They can manage their self-governed, so to speak. So the trusts are those organizations which are created with a very specific terms of reference, with the ability to manage their own funds. They manage their own business as they see fit. So that's the difference between a trust and a non-trust organizations. And they also have the ability to do a 3-year financial rolling plan rather than a year-on-year plan, which is what the government had for those organizations before. So the money you receive in April has to be accounted for by end of March next year, and very little carryover could have been taking place, or any transfer of that wouldn't be allowed to do. So you need to account for every activity there. With the formation of the foundation trust, it so happens that they are in control of their own financial management. So they have a 3-year model, so they don't have to go with that year-on-year financial planning.
Thank you for that, Bala. I think you very well explained. Since you coming to the care management, because that's what we spoke about.
Yeah.
So, what is the technology adoption in terms of percentage? How much of percent, especially on the care management in the NHS, is they've adopted technology?
I think technology in UK is very relative. So it's like poverty. We don't have absolute poverty in the UK. It's a relative poverty because of this social system framework. Whereas if you look in India, there's absolute poverty. Okay, so the relative poverty is how rich or poor you are in comparison to your neighbor. Your neighbor may be a millionaire. You may be halfway through there, but you still consider yourself to be poor in terms of financially in terms of your neighbor. So very similar to that, the UK technology is very relative. There's no absolute adoption of technology is there and across all care platforms in the healthcare. It's the maturity, what we call the digital maturity of the organizations is varying. It's not a level playing field. It depends upon how much the management has looked into their infrastructure development. So a vast majority across primary, secondary, community mental health and palliative are all, there's a track record of digitization. So I've been here for nearly 32 years now. And in my 30 years of career in the NHS, I've seen the gradual progression of digital technology that's come into vogue. It's now become, second to none. It's become so routinely embedded in the organizations. There's still a long way to go, and digital technology differs by people's definition. So if you look at the history, how health technology was evolved in the NHS. It started in labs in the diagnostic area. The labs and the radiologists were the first people to adopt technology through their analyzers, through bringing use of technology to do their work routinely, integrated that as part of them. The other two groups of people who sort of spearheaded a lot of the transformation of digital transformation in healthcare. So through the formation of databases, through the formation of what we call patient administrative systems, collecting, having visibility of those records, and then slowly that moved into what we call legacy EPR systems, electronic patients record systems, and then slowly developing legacy departmental systems like radiology systems, lab systems, and then slowly integrating them. So having access to a single point of data storage and sharing this data within that organization. And this is now then was siloed by primary care doing their own EPRs, the secondary care doing their own EPRs, tertiary care doing their own EPRs. But in their own respective, they were full-fledged. Then they were having access to the data, but they were blinded to what is happening to the patient along the patient's journey. So a patient coming from primary care to secondary care, the clinical data will not flow electronically to the other hospital. So there was still paper-driven, paper notes, paper letters kind of thing. Over the last 15 years, there was a huge drive to do that kind of a interoperability push has been that to make data visible and make access data available at the point of care. So that started with what we call the NHS spine, so to have a conduit against which all the data can be piled in. It has had varying degrees of success, but regionally now, rather than integration, interoperability has been a big successful win. Patients are now getting, or clinicians are now getting access to the data. And it also meant it's patient-centric system. So patients have control of the data. They can see what data has been held, what of information of theirs is held within the various systems. They can also contribute to the data through wearable technology these days. So they can upload their, blood pressure monitoring at home, their, diabetic monitoring at home. They wear ECG, portable ECGs. That recording is then uploaded onto the system. So there's a lot more contribution, data points that has been contributed so that the clinicians are kept well informed. Obviously, there are certain regulations for certain types of tests. They are making sure the digital applications are calibrated. They're all medical devices, so they need to go through the routines of validated data that is coming before to make informed clinical decision. So the adoption of technology in the long and the short is more or less absolute in all aspects of care delivery.
About what we do at DigiNxtHlt, we are adopting AI-based technology for people who are mainly on the seeking emotional and mental well-being. And two questions that I had in my mind. First of all, is an alternate therapy a regular practice in the UK? And my second question is because we are doing so much around the music therapy. Is music therapy an accepted practice in the UK?
Yes, I think answers to both your questions is yes. I mean, what we call it as complementary therapy here to mainstream. Complementary therapy has had its own uh, tested history in the UK. It wasn't very well accepted when it started off, but it has become pretty mainstream these days. By complementary medicine, you have various definitions. What do you mean by complementary therapy? So complementary therapy could be like homeopathy, Ayurvedic medicines. You have yoga, you have herbal medicines. All that kind of category. And it has become accepted. Prince Charles was a big advocate of complementary medicine, and that's sort of he lent his voice to that, and it has now become mainstay. In addition to that, in terms of some core aspects of work, especially my experience in cancer care work, made it extremely aware that we're not treating the person, we're not treating the disease, we are treating the whole person. So whole system therapy. It's not just the disease area you're dealing with, the tumor group or the tumor area you're dealing with. You're treating with the person as a wholesome, and they then tend to have a lot of emotional needs. As I said in our earlier conversation, a person with cancer would not really acknowledge they've had cancer till the day they have been diagnosed with the disease. So they could be living with the tumor for last 5 years or even 15 years. But then they feel unwell, they've had a test done, and somebody then confirms that you've got a tumor which is now malignant tumor, and then the whole world falls apart. uh, you're not the person you were yesterday when you didn't know. Ignorance was bliss. So the mindset to handle that is not the disease management. It is how do you handle the emotional capabilities of the person, so the support you need to provide them to come to terms with their own illness, and in how do they cope with the illness in the later on. So much of this therapy is, as you go through the treatment, irrespective of what your starting point is, how acceptable you are or how not so acceptable you are of the diagnosis, you still go through a transition phase of coming to terms with your disease, coming to terms with the treatment that you need to have, and coming to terms with the clinical outcomes that is being predicted for you. you know None of these predictions are very accurate, but it is based on statistical analysis of having data that similar patient group may have had in the past. So putting that into context, emotional therapies, anything like what we call as, there's music therapy, there is art therapy, there's dramatics. They've all been recognized by as allied health professions. So it's a recognized course of treatment here, which is to provide that enablement or enabling support for the patient to come to terms with their diagnosis, or also progress through the illness. How do they find, how can they shift their mind off their worries, of their other things. So that's a standard component of care that these days, and complementary therapy has become a mainstay within the healthcare practice as well. Hope I've answered that question.
Yeah. Uh, you know, because you've spent so much of time in the NHS and like you were mentioning, especially on cancer care at the Christie
Yeah.
Hospital. So, is music therapy being adopted? While you said, it's a complementary therapy, is it being adopted, even during care, right? Because once a person has been diagnosed, during the entire course of the care, whatever
Yeah.
stage of cancer he or she is undergoing, is it something that is being used at the NHS bundle?
Yes, I mean, music therapy is very specific because it is a very recognized and well established intervention. So for both psychological, so in the psychological clinical intervention space. So these are people, these are adopted in areas, not specifically cancer, but these are specifically in those where they have affected by injury. They're unable to communicate, or they are, they have limited capacity to share their emotions or feel, that kind of thing. So they are either by illness or disability, through psychological, emotional, cognitive, communicative, and social needs. So those are the broad areas that music therapy tends to cover, and they are qualified people. They are, fully qualified music therapeutic people are registered. They've got to register. They have to register their own profession with the governing body, and they are highly skilled people in terms of what they can deliver and how they can tap into those emotional things. And it is a very, personalized care providing. So it's not, one size fits all. They don't pick and say, you know I like this music and that's what you want to listen. So it's more what the, how you tease that out from the patient who is not communicative is an art in itself.
Right. So it is part of the mainstream then,
It is part of the mainstream, yes.
right?
So as we say, um, we have different professional groups. We've got what we call multi-professional group treatment. So whenever a patient comes through to care, uh, it's just not the doctor who sees them. The doctor will then assemble a team, what we call multi-professionals. So who are the key professionals who need to be part of this patient's care as part of the care plan. So if it could be speech therapist, it could be, music therapist, it could be, dietitian. So they will assemble a whole cohort of people to discuss that patient's case, and they all play a part in providing care to that patient along the patient's journey.
Right. You know, thank you so much, Bala, for sharing your viewpoints
Yep.
and on the NHS and around music therapy, because we at DigiNxtHlt are embarking on this journey of delivering personalized uh, music therapy based on individual needs. We're using AI-based technology for delivering for personalized needs, and it is very heartening to know that this is part of mainstream in the UK. And thank you so much for sharing your views, and looking forward to speaking to you again, Bala. Thank you so much.
Thank you very much. Thank you.